Shoulder external rotation mobility is one of several planes of range of motion in the shoulder that we assess as part of our baselines for an orthopedic evaluation. In and of itself, it's not diagnostic, but it is an important piece of the puzzle to understand for shoulder complaints or upper extremity complaints. There are many ways to assess external rotation of the shoulder joint. I almost always test it in standing, and if I need to, I will have the patient lie down in supine and assess it in that position. But in standing, I have the patient place his elbows next to his trunk, externally rotate the shoulder as far as possible, actively, then I will support the elbow and apply some pressure at the distal forearm or wrist to take the joint passively to its end range external rotation. With any range of motion testing, we are looking for not only quantity, but quality. Where does it hurt? Does it hurt? Does it have a normal end feel, etc.? Is the movement, aberrant, or is it moving smoothly and fluidly like we would expect? Secondly, in standing, we can assess external rotation of the shoulder in the functional external rotation position. I'm looking for the fingertips to hit somewhere, in the upper thoracic spine, although it's variable from person to person. Left to right is what we're really looking for when it comes to extremity joint disorders or extremity joint signs and symptoms. And, a change in terms of range of motion left to right is usually important, and a difference in pain or sensation. In supine, I'll have the patient lie on his back and then take the shoulder into external rotation in that position, making sure that I have the elbow in the plane of the shoulder joint. We don't want the elbow on the table, which is lower or behind the shoulder joint. I want it in that plane. I'm looking at it usually passively by applying some pressure again at the distal forearm or wrist. We're looking for about 90 degrees, though I've seen patients with, north of 120 degrees. Obviously, if someone's 80 degrees bilaterally with no symptoms and it doesn't seem important to their presenting diagnosis or disorder, then that just might be their normal. But anything less than 80, I might be a little bit more curious about. The arc of motion between end range internal rotation and external rotation can also be an important measurement to keep in mind if we're curious about lack of mobility in the shoulder. Again, diagnostically, this one piece of information is not going to tell us what the disorder is, but when we combine it with all the other mobility tests of the spine and shoulder, nerve tension, strength, functional deficits, history, we can start to piece together a diagnosis. External rotation is commonly limited in frozen shoulder, although frozen shoulder isn't a very common disorder compared to other disorders of the spine and shoulder. But of course, a severe lack of external rotation in conjunction with lack of motion in other planes may rule in frozen shoulder. I also find that thoracic, neck, and shoulder joint derangement can cause a loss of external rotation of the shoulder. In comparison to other motions of the shoulder joint, however, external rotation is not one that I'm typically finding is restricted. I find a lot of lack of elevation, either in flexion or abduction, some lack in horizontal adduction across the body, and then very commonly into functional internal rotation or sometimes into extension. But external rotation doesn't seem to be one that's, like I said, as commonly restricted, but it could be a frozen shoulder that's causing it. It could be a mechanical problem in the spine or shoulder. If it's a mechanical problem, that means by definition that moving the problematic joint into the right direction or two will restore that external rotation to normal, as well as restore all the other signs and symptoms to normal. For example, if there's a shoulder joint derangement, moving repeatedly into shoulder extension might restore that external rotation. If it's in the neck, possibly repeated side bend. If it's in the thoracic spine, possibly repeated rotation. As a clinician, I work with the patient to establish if that's the diagnosis, and then look together to investigate what is the precise movement that that patient needs, which part of the body and which load, which force will restore all normal range of motion to that shoulder. There are, of course, other diagnoses other than mechanical joint problems in the spine and extremities and frozen shoulder that may restrict external rotation, but it's typically not ligamentous or muscular that I'm finding. So I'm thinking about those diagnoses first, and then possibly other orthopedic or non-orthopedic disorders.